Thank you very much for the invite, Dada. And this session is a very interesting session in the sense that to be getting educated from Dr. J.C. Mohan and Shantanu, it's always a pleasure. So my topic this evening is discuss primary versus secondary MR, what the clinician needs to know. I'll start with a premise, which is a very bold premise to make. And that is that, but for the suffix of MR, primary and secondary MR are two different disease entities, and shall attempt to defend this premise of mine in this presentation. So when you look at the definition per se, I'm not going into the nitty-gritties, but by and large, primary MR is a disease of mitral valve apparatus. However, secondary MR is a disease of ventricle or atria. Now, the gray area is annulus. We are not going to talk too much about it, but we are just trying to distinguish whether these two entities are two different entities and how much do we need to know as a clinician. We need to know as a clinician because the diagnostic criteria are a little different, medical management is a little different, surgical management is different, and new toy for the boys, which is the MitraClip for the transcatheter end-to-end repair, is available. And where do we stand? Let me just try to discuss this out. The cardinal diagnostic difference between secondary and primary MR is that in primary MR, the mitral valve leaflets and cords are usually normal or minimally thickened. So if you have grossly thickened leaflets, then you are looking at primary, and this is a cardinal difference, so to say. This is where the primary MR would lead from leaflet involvements, from chordae, from papillary muscle, and of course the annulus, which is borderline because this annulus can be an involvement in primary or secondary MR both. Here is a typical example where if you look at this, you'll find that the leaflets are grossly thickened, and this is a typical rheumatic mitral regurgitation, and it is eccentric. Centricity and eccentricity also some bit try to differentiate the two, and most of the times the central jets are seen more so with secondary MR and lesser so for primary. Now, when it comes to the management, primary MR is mechanical problem of the leaflet coaptation, and that has only a mechanical solution. So if you look at the recommendations from the 2020 valve recommendations from the EZECHO group, you'll find that for everything, wherever it is needed, except the places where there is a high risk surgical risk, TAVR is recommended. Otherwise, only mitral valve surgery is recommended, and that too mitral valve repair. I'll come back to this repair business when I'm talking about secondary MR, because this repair business is almost getting its sheen out as far as replacement is concerned in secondary mitral regurgitation. Now, we are not going into the discussion that when an asymptomatic primary MR should be operated, but a reasonable cutoff is that if the ejection fraction is falling lesser than 60%, or the left ventricular end systolic diameter is going greater than 34 millimeters, this is the time, even for asymptomatic, you should be pushing for a valve replacement. And this valve replacement or valve surgery, and this valve surgery is mitral valve repair, if you can do, except we still see a lot of rheumatic, and rheumatic, the leaflets are difficult to repair, so might as well do surgery for them in form of replacement. Now, the purists can debate that it is not 60%, it is 64%, and the left ventricular end systolic dimensions is not 40 millimeters, it is 37. I'll leave that for discussion for the purists. Now, till such time you are not operating and you want medical therapy to continue, the problem as against secondary MR is that in primary MR, if the LV functions are fine, then vasodilator therapy is not indicated except if the patient is hypertensive. And this becomes a reasonable difference of therapy as against secondary MR. Now, as by and by with primary mitral regurgitation, if the LV dysfunction happens, then where are we as far as medical therapy is concerned? Beta blockers unquestionably have proven that they are beneficial in primary MR with LV dysfunction. Now comes the ACE inhibitors. ACE inhibitors have not been effective in experimental MR. So if ACE inhibitors are not beneficial, intuitively ARBs also don't become beneficial, and then ARNI also are a little bit of a suspect because they all work through the RAS agent. Another RAS agent, which is supposed to be a very, very strong tool in LV dysfunction and secondary MR, is MRA, aldosterone antagonist. But the premise is that basically aldosterone antagonists are effective because of their antifibrotic efficacy. And if this function of theirs is not to be utilized, then what is the benefit? Because in primary mitral regurgitation, there is very little of fibrosis. Hence, MRAs, how much will they be beneficial? We don't know. Let's look at the pathophysiology of functional mitral regurgitation, which is the secondary MR. Basically, why is it called ischemic? I don't know. It's myocardial infarction, which leads to remodeling. And as this remodeling develops, the mitral annular dilatation occurs, the papillary muscles pull, there is a tethering, and there is a central mitral regurgitation which happens. I'll go back onto this cartoon again because it's very important that where is the deficiency? Deficiency starts from here, which is the myocardial infarction and LV remodeling, and keeps pulling. There is a tenting, there is a tethering, and an annular dilatation occurs, papillary muscle dysfunction occurs, and there is a mitral valve leakage, which is central in origin. So basically, the mechanism of IMR could be papillary muscle rupture, lesser so, infarcted papillary muscle, but no rupture. And the commonest, which is almost there in 75%, which we are trying to target today in the discussion to differentiate primary versus secondary MR, is functional MR. And this is MR in presence of structurally normal mitral leaflets and subvalvular apparatus. Now, this is Carpentier's classification of ischemic mitral regurgitation, and actually whatever is available is for annular dilatation and restricted leaflets, which is type 3B. So it is basically because of coronary artery disease, usually but not always as a result of previous myocardial infarction, and must be differentiated from MR with incidental CAD. Why? Because as MR increases, the mortality increases. What happens when you reduce this MR? I'm not too sure, but one thing is decided, that even if there is mild MR, this is an independent risk of post-MI mortality, and presence of MR provides important information for the risk stratification, no doubt. Now, ischemic regurgitation and multivariate predictors of overall survival is expressed as effective regurgitant orifice area is that if you look at the diagnostic criteria for severe mitral regurgitation in primary, then effective regurgitant orifice area should be more than 0.4 or 40 millimeters square. However, as you have an ERO greater than 20, your survival or your event rate increases in a secondary MR. So the cutoff still is 40, even in the latest discussion in the American Heart Association paper, but the worsening of events starts the moment ERO is more than 20. And this is the importance. MI with or without MR, the survival is lesser if there is an ischemic mitral regurgitation. With the increasing degree of EROs, the survival is worse off. Similarly, if you have regurgitant volumes which are higher, obviously the survival is worse off. Now, there are certain balancing of forces of mitral valve leaflets, and this is what is important when you are trying to capture the events. So when it comes to evaluation, you have to calculate the tethering length too. So because as the apex keeps moving distally, the tethering length increases, and this increasing of tethering length increases the mitral regurgitant orifice area, which again is a bad prognostic indicator. So whether it is effective regurgitant orifice area versus tenting area, or the annular contraction, or the end diastolic volume index, everything has a correlation, except that annular end-diastolic volume index has a correlation which is not very robust. It is close to 0.49, but again, it is statistically very significant, 0.0001. Leaflet morphology is to be mentioned because this is the thing which captures primary versus secondary. The thinness is the cardinal difference. Tethering of the leaflets can occur. Bend on the anterior leaflet is there, but the coaptation point is there. It is important to measure the coaptation distance because if it is lesser than 2 millimeters, then they don't become one of the best candidates for tear, or which is the mitra clip, so to say, as we have started knowing it, because that is the only one which is available in our country. This is the bend, and the thinness, if you see, is very thin. Then there is a coaptation distance. This coaptation distance has to be measured from the annulus till the time where there is a coaptation. And if it is greater than 10, again, it matters because the prognosis is worse off if the coaptation difference is more. Tenting distance, the LV diastolic dimensions, LV volumes, the sphericity index, the distance between the two papillary muscles, the angle between the posterior mitral leaflet and the annulus, the coaptation distance, and the tenting area. These are the ones which have to be, should be calculated because they all have, if nothing else, coaptation prognostic value. Now, where are we as far as functional MR is concerned, as far as management is concerned? Because the fight continues. Few studies say it improves survival. Most studies say it does not improve survival. Few studies say it improves your NYHA class. And few studies says that probably it has nothing to do with NYHA class. These are certain things which people have tried. The commonest is ring annuloplasty. But the problem with this is that this came in 2003. A paper was in 2001, which said that surgical correction of 2 to 3 MR improves survival and LV function. And soon after, in a couple of years, STS came and said that there is a 3-fold high operative mortality, and there is a 30% recurrence within 1 year of ring annuloplasty, which is almost something that you should not probably do. Now, there are two schools of thought in ischemic mitral regurgitation. One is rationale for conservatism, and another is rationale for being aggressive. The rationale for conservatism is that revascularization improves regional wall motion and corrects MR, increased operative risk with valve surgery, small LA difficult to expose, failure of annuloplasty, consequences of unintended mitral valve replacement, just in case you have to land up with the replacement. Survival and NYHA class are not influenced. These are basic facts on which the rationale for conservatism exists. Rationale for surgery, as against this, there is this aggressive school of thought too, that IMR or ischemic mitral regurgitation is dynamic and may be underestimated. Bypass will not correct it. And related to scar and annular dilatation, the significant ischemic MR results in late symptoms and decreased survival. Annuloplasty, often feasible and almost always corrects moderate MR. Reportedly, high mortality is dated without leaving it, and potential need for reoperation, presence of patent grafts for surgical correction. So we also were a part of this fraud, so to say, that there is a device called the coapsis device, which, if you look at it, is something like there is a cord which travels right across the LV, and this is like the old days telephone. And all you have to do is you have to keep pulling it up and keep pulling it so that there is a constriction and there is a coaptation becomes better. And how you prove it in the theater was that you continue to push in saline from the LV, push it, and keep pull the string till such time the coaptation became better and the leakage stopped. So this was a coapsis device which we also were also a participant of, and we did it in annular dilatation with LV dysfunction or restricted leaflet mobility. And when we saw this was the TRACE trial. And if you look at it, the results were very dramatic. This is pre-coapsis and this is post-coapsis, where there is hardly any mitral regurgitation. the leakage improved significantly. And not only that, it continued to reduce for next 1 year. But what happened? The survival pattern was no different as against conservative ones. And this was something which kind of upset the whole system, and we were forced to relook at whatever it is. Now, this is coapsis device, which is a transcatheter edge-to-edge, not coapsis, sorry, mitra clip device, which is a transcatheter edge-to-edge repair. And the concept was that functional mitral regurgitation, with increasing severe functional mitral regurgitation, the survival was poor. So premise again was that if you correct this, you'll make the patient live longer. So this was the new toy for the boys, and we claim to do the first one here in our hospital, where there is a device which captures the A2 and the P2 and clips them and kind of, it's a non-surgical Alfuris stitch on the mitral, and this is something which reduces mitral regurgitation, no doubt. This is the pre and the post. If you look at the pre and the post, you'll find that the mitral regurgitation improves very significantly. And we need to be very careful, because this is one place where 3D is very, very beneficial. Now, the crux of the matter came that back to back in 2018, two studies surfaced. The first one was MITRA FR, which is from the eastern side of Atlantic. And the second was COAPT. For reasons known and unknown, it got delayed in publication, though it was supposed to be released earlier. But the two studies for LV dysfunction showed miraculously different outcomes. COAPT, excellent. They said this is the way to go forwards. MITRA FR says that, listen, be cautious, because we are not too sure what happens. Now, we can keep debating till cows come home that why were the differences so much, whether it was the effective regurgitant orifice area, which was different in the two, the left ventricular end diastolic volumes were more in MITRA FR, the number of clips they used were lesser, but it has left all of us with suspicion. Not only that, when they came out with message from COAPT trial, it says treatment with mitra clip by an experienced operator substantially improves prognosis, reducing heart failure, hospitalization, improving survival, quality of life, and functional capacity. So the direct implication was that people eastern side of Atlantic were not good operators, and we from the US are better off. And that is the reason why there was a difference also. This was also one of the reasons which was discussed. Now, we are in a flux. People are still trying. There is an internal direct repositioning of displaced papillary muscle, infarcted application, external repositioning of displaced papillary muscle, caudal cutting, PCI like Alfuris stitch, again, remodeling of mitral annulus through coronary sinus, yet to show clinical benefit. Now, as far as current recommendations for intervention are concerned for secondary MRs, that there is a space for mitra clip or TR, because but the caution is that the LV end systolic diameter should be less than 70 millimeters and pulmonary artery pressure should be less than 70. Of course, the usual exclusion criteria are there, that the cooperation distance should not be lesser than 2 millimeters. The calcium should not be there between A2 and P2, and whatever are the usual contraindications, we are continuing. Now, there is a very interesting thing. I said that I'll come back to you when I'm talking about the intervention in secondary MR, and that is that still surgery, if needed, it's class 2B indication, but surgery, if be needed for secondary mitral regurgitation, then chordal sparing mitral valve replacement may be reasonable to choose over downsizing.
Samir, a gentle reminder to wind up.
So that's fine, sir. I'll just take 2 more minutes. That, not even that. So it is, surgery is replacement here in as against, but survival benefit is very, very dubious. Why? Because MR is a simple marker of LV dilatation and dysfunction. People die of not MR, but they die of left ventricular end diastolic pressure being high. Because sorting out MR prevents only regurgitation in systole, which is 1/3. But what about diastole when the mitral valve is open and the LA pressures keep building up in diastole more than this, so certainly lesser in systole. Rings to be effective should be undersized and creates mitral stenosis. There are certain things which need to fix. These are the ones. If the heart is more globular, it is bad. If the end systolic volume is more than 150 odd, it is bad. Higher wall motion scoring index, it is bad. Large tenting area, it is prognostically bad. Large distance between coaptation point and annulus is bad. Large angle of posterior angle more than 45 is bad. Multiple jets is bad. So where are we? Medical therapy must for all, but difference exists between primary and secondary. Some may benefit from CRT if there is a wide QRS. PCI usually not sufficient to reduce mitral regurgitation. Combined therapy, CABG, MBA, a role not yet defined, but there are certain non-controversial things. If there is severe ischemic MR, ERO more than 40, when undergoing CABG, that's a class 1 indication. Role of exercise needs still more validation. So this is my last slide, which say I have offered my defenses. Now the verdict rests on you, but I shall still insist that primary and secondary MR are two different disease entities. Thank you very much for bearing with me.